Thank you. Good afternoon. It's a pleasure to be here at the conference. So today I'm going to address the issue of risk compensation. Not an issue I'm very familiar with, but I'll do my best. So these are my disclosures. As you know, we have multiple biomedical interventions available today to prevent HIV infections. Condoms, which have been available since the 16th century to prevent syphilis and HIV in the late 80s, male circumcision, and we have the drugs which have proven to be very effective to prevent either transmission or acquisition of HIV, post-exposure prophylaxis, treatment of HIV infection, or PrEP. Vaccine is not yet on the horizon. When we think about risk compensation, it's clearly one of the most critical issues in the implementation of these biomedical innovations. And the fear is that increase in risky sexual behavior may actually counteract the biological efficacy against HIV. And that's the reason why regulatory agencies and the European medicine agencies in particular asked Gilead to implement in their marketing authorization for PrEP a risk management plan to assess the public health impact of PrEP. If we try to define risk compensation is the adjustment of the behavior in response to a perceived reduction in risk. And there are potentially two aspects in risk compensation. One is what could be called behavioral adaptation, when the changes in behavior are triggered by a safety measure induced, for example, with PrEP, a reduction in condom use. There is another aspect also that could be called behavioral disinhibition, where there is a lack of restraint with more risk-taking behavior, like an increasing number of partners, an increasing number of sexual acts, more chemsex, for example. But both these measure of condom use, a number of partners are, as you know, self-reported measures of risk compensation, and therefore they are not fully reliable. That's why we need a measure that is more objective, and I think STIs, although indirect, are the best objective measure to assess risk compensation. But it's also, as you know, the most feared consequence of risk compensation. And finally, when we want to address the issue of risk compensation, we have to assess it both at the individual level, but also at the population level in those people who don't yet have access to these innovation, but who may actually feel a lower risk and therefore have a lower use of condoms or higher risk compensation behavior. Let's now look at the data we have with the biomedical intervention using drugs. If we look at change in sexual behavior among people using post-exposure prophylaxis, I think this study by Martin and colleagues in San Francisco was interesting. They looked at nearly 400 gay men, mostly gay men, who received 4 weeks of post-exposure prophylaxis and who benefited also from 5 counseling sessions. And they followed these men for a year. And during this year of follow-up, what they have seen is actually a decrease in the rate of condomless sex and no change in STIs. But despite these safer behavior over time, they still reported that 17% of these individuals needed another course of PrEP. And in addition, 4 actually seroconverted with HIV, 3 were MSM. So the incidence of HIV in this cohort was actually very similar to the incidence in San Francisco at that time among gay men. If we look at the data now reporting sexual behavior in HIV-infected people using ART, and this is a meta-analysis reported by Dole and colleagues summarizing data from more than 56 observational studies. And as you can see at the bottom of the slide, unprotected sex was actually lower in people using ART as compared to those not using ART. And the rate of STI was also lower in those on ART. However, regarding the changes in behavior in those injecting drugs, there was no change. If we look at more recent data in people using ART, I think this is an interesting study from Alison Roger in the START trial, where naive HIV-infected patients were randomized to receive either immediate ART or deferred ART in people who had high CD4 cell count. And when they look at the rate of condom-less sex with an HIV-negative partner in the study and compare the rate at baseline to the rate at 12 or 24 months, they overall saw a decline in the rate of condom-less sex in both arms, the immediate and the deferred arm. And if we look at MSM, for example, at baseline, this rate of condom-less sex was in the range of 20%. It declined to 13% with both immediate or deferred ART, and this was sustained at week 24. Among heterosexual men and women, the same trend, a decline in condom-less sex from baseline to month 12, and at month 24, maybe a higher, actually, rate of condom-less sex in those starting ART as compared to those in whom ART was deferred. If we now take a broader look at the incidence of HIV and STIs among MSM, and these are data from England from 1996 to 2015, you could see that following the implementation of combined ART in the 1960s and post-exposure prophylaxis in 2000, you can see that the trend in the number of new HIV diagnoses in blue continued to increase after year 2000, showing that there was no public health impact of PrEP and treatment, at least in England, in this gay community. At the same time, you could see that a few years after implementation of ART and PrEP, there was an increase in syphilis in red and gonorrhea in green that actually predated by many years the results of the PROUD trial. Let's now focus on risk compensation in people using PrEP. What are the data we have? And this is a picture taken in Melbourne. Initially, we had data on condom use in people randomized to PrEP or placebo in a number of studies. And in that context, actually, we didn't see in blue here any change in the proportion of people having condom-less sex, because people didn't know for sure whether PrEP was effective or not. But as soon as we got the first results of high efficacy of PrEP during the open-label rollover study of the IPEGAY here, we've seen an increase in the rate of condom-less sex, which was significant. At that time, though, there was no change in the median number of partners, the median number of sexual acts, and the increase in STI was actually not significant. But if we look now at the community-level changes in condom use with casual partners among MSM, and these are data published recently from Australia in Sydney and Melbourne, when they looked at more than 1,300 gay men surveyed from 2013 to 2017, what you can see on the slide is that the rate of people here having condom-less sex and being HIV negative, not on PrEP, actually declined from 46% in 2013 to 31% in 2017. At the same time, those who were HIV negative, not on PrEP, and who have condom-less sex, their proportion remained roughly similar from 2013, 30%, to 2017, 29%. And the main changes are seen here in gray in those who were HIV negative on PrEP and we are using condom-less sex. This proportion was only 1% in 2013, 5% in 2016, and 16% in 2017. So with the rapid actual implementation of PrEP in Australia, you could see a rapid decline in the use of condoms, in particular in these PrEP users. If we look now also at other findings from this analysis, you could see that the rate of STI also increased quite dramatically from 2013 to 2017, especially between 2016 and 2017. But at the same time, the rate of testing for HIV also increased quite impressively. And this is partly due also to PrEP, because with PrEP, you test for HIV every 3 months. At the same time, you see that the proportion of people with HIV on ART also increased, and the rate of patients on ART with undetectable viral load also increased. And so overall, this increase in PrEP uptake and the decrease in condom use coincided with a reduction in new HIV diagnoses among MSM by 16% in Victoria and 11% in New South Wales. Let's focus now on STIs. And again, if we look at data from randomized studies, like here in the PROD study, you could see that the rate of STI was quite similar whether people were randomized to immediate PrEP or deferred PrEP. But if you look at the post-randomized phase of the study, and these are results reported by White at Paris last year, you could see that over time there was an increase in the rate of syphilis. And Traeger recently reported in CID a meta-analysis of the effect of PrEP on STI diagnosis among MSM, and they showed that there was overall a 24% increase in the rate of STIs in those using PrEP, especially an increase in rectal STIs and rectal chlamydia in particular, and this increase was even more obvious in recent studies. And indeed, we report the experience from our site, and this is a study in press now, where we follow more than 1,000 people on PrEP in our clinic. Now it's nearly 2,000. And we actually measured changes in sexual behavior looking at the rate of condomless sex, which increased from 53% to 79% at 12 months. We also saw a modest, though significant increase in the overall STI rates, mostly an increase in rectal chlamydia and gonorrhea from 11 to 20%. So this is consistent of the study. But if you look at the overall increase in rectal chlamydia in France among MSM, you could see that this increase, again, predated the introduction of PrEP, and this increase was not only among HIV-negative MSM, but also, like you see for LGV, a majority were actually HIV-positive. Interestingly, Golub and colleagues at CROI this year reminded us that condom use is not the only or even the most significant driver of STI rates, and there are other drivers of STIs: young age, the number of casual partners, and the history of STIs. And in that study, neither the overall condom use or the change in condom use were associated with an STI diagnosis during follow-up. And these data are confirmed by a poster presented here by the PrEPX team, confirming and extending these findings. Why are we seeing such a high rate of STI among MSM on PrEP? Well, Timo Nori and colleagues reported at EACTS last year that indeed people on PrEP test more frequently for STIs, 87% as compared to 69% in those not on PrEP. And these are the results from an eCDC Hornet Survey. Also, and these are data from the US, we have seen over the last few years an increase in extragenital testing for chlamydia and gonorrhea, especially in male, on rectal swabs, pharyngeal swabs, by nearly twofold. Now let's hope that the model published by Ginis and colleagues from the CDC is right, and that the incidence of gonorrhea and chlamydia could decrease among MSM using PrEP if we test them more frequently for STIs. And you can see that the decline in the incidence rate here is quite strong if you test them every month or every 3 months. And the decline could be also higher if you treat everyone for STI. So that's another incentive to combine PrEP and STI testing in people using PrEP. So in summary, I think TASP and PrEP implementations have been associated with high rates of condomless sex and STI, which actually did not undermine the high efficacy against HIV transmission or acquisition. I think these new interventions should be accompanied by measures to reinforce individual perception of the STI risk and behavioral changes, including condom use in addition to PrEP. Frequent testing, early diagnosis and treatment for both HIV and STI should help reduce their incidence. And I think PrEP cohorts are a great setting to assess new strategies to prevent STIs. But STIs should not be used as an excuse to deny or defer access to PrEP. And finally, I think community and individual empowerment is key to counter the increase in STI associated with these biomedical interventions, and we should continue to work with the community and the individuals to make them understand that STI now is the next goal. With that, I'd like to thank you for your attention, and this is a part of my team in Paris, and the many sponsors will help us to conduct this work over the last couple of years. Thank you.